is John Buchan, and I have been a licensed social worker since 2000, so it's been a little bit over 20 years now.
What you guys do?
I'll give you a thumbnail sketch of it. Ours, Young Children's Health Center, is a community-based pediatric clinic that provides comprehensive primary care services, specialty medical services, as well as social work and behavioral health services. And the foundation of our clinic is a model called integrated primary care, where social workers and behavioral health professionals work side by side with medical professionals, nurses, doctors, nurse practitioners, to deliver seamless services to the people who are here in the community. We've been kind of designated by the Department of Health as the pediatric clinic of choice for newly arrived refugee families, just because we have the most experience and kind of the most diverse staff in being able to serve their needs. There's a lot of benefits to that kind of model. The primary one is that it's more efficient in that we have teams of people who can work in a multidisciplinary manner to respond to the family's complex needs. But then another important part of it is that it really reduces the stigma of reaching out for social services or behavioral health services. And so now people can come to the doctor's office if they're sick with the flu or if they have asthma, as well as for problems if there's family violence or there's depression. There's a strong recognition about the social determinants of health and how issues like poverty, mental health issues, the loss of a parent, adverse childhood experiences, how those are very, very, very important to the long-term health outcomes of individuals. The clinic opened in 1981 and was created by the founder, a lady by the name of Dr. Carol Guile. And so from very on, she was very forward-thinking in that she understood that for the people who lived in this community, issues related to financial well-being, community violence, family violence had a greater impact on kids' life development and well-being than did infectious disease. We've been fortunate over years. We've really grown a lot, and our program now probably has one of the largest integrated primary care programs in the country. The community that we serve, like Paula mentioned, is one that's very diverse. We're located in an international district, and part of the reason that this is the international district is that it has some of the most available and least expensive housing in the city. And so one ways of thinking about this part of Albuquerque is it's kind of like a border town that's maybe 200 miles away from the border. And like a lot of border towns, there's a lot of excitement and richness, but it also has like a lot of challenges. Everyone here, other than myself, is with our home visiting program.
Babies. Hello, my name is Claudia Mata. I work with Paula and Julian, my beautiful coworkers. And I've been a home visitor for, 1.5 years, almost 2 years. Another services that we provide, it's, to meet families' needs with resources. There's, many resources that family needs while you're working with them. It could be anything, helping them applying for food stamps, cash assistance, Medicaid, and tons of different resources.
My name is Julian. I came from Rwanda, Africa. In 2017, I've been here in the United States for 3 years. So my role in the clinic is to provide a home visit, and case management when needed. But I provide a home visit to most of the African community who speak the African languages and some English speaking too. There is Kirundi speaking, Kinyarwanda speaking, Swahili speaking, French speaking, and English speaking, some of them. So right now I'm learning Spanish, of course.
Are important, in addition to the integrated primary care model, all of our staff has extensive training in trauma-informed care and different trauma-informed care treatment approaches. One of the approaches, or one of the strategies we use regularly, is a model called attachment regulation and competency. And that's a model that specifically helps families and helps providers understand the impact of trauma and how it affects people. Another theoretical model that we use a lot is solution-focused therapy, because given the population we work with and the diversity of the population we work with, we found that those specific models offer the flexibility for us to be able to individualize service plans and work within people's distinct kind of worldview. I think both are flexible and pragmatic, right? And so one of the things I like about solution-focused therapy, or the solution-focused approach, is that it's strength-based, it promotes resiliency, and it helps people to contemplate a future where they're able to find a solution to the particular barrier or problem they're experiencing. And it really works well in terms of, I think you can apply it well to people's narratives, their immigration narrative, right? And it allows families to define their problem within their own worldview, and the skills that come along with it are kind of just an approach to bring them along to finding that solution, right? As opposed to defining what the problem is for them and labeling it as a deficit of some type. The thing that I like about the ARC model is that it's flexible and really emphasizes psychoeducation and regarding the impact of trauma. And so it really allows us to educate people and normalize people's experience about the physiological impact and developmental impact of traumatic events. Normalization and connection, I think, are really very profound, interventions that you can do both of those models. Creating a safe space that allows people to tell their stories breaks that sense of isolation, which often is the most toxic part of traumatic experience. That kind of being able to develop an affinity and a connection with another person can be very healing. Even though
Claudia follows about 22 families. The majority are from Mexico, some are from Honduras, El Salvador, or some other countries in Central America and Latin America. Julian, most of your families are from African continent countries. Can you say which countries?
Most of the moms I have, there is some of them came from Congo, from Rwanda, from Burundi, from Tanzania, from Ghana, from Zimbabwe, from Nigeria, and from Guinea-Bissau.
And then Central Africa?
Oh, Central Africa too,
okay.
Yes.
And then some of the families I see are coming from Cameroon, China, Syria, Afghanistan, and Pakistan. We have maybe 4 to 5 families who are English speaking as a first language, and out of the 60, all others are second language is English, and most of them are monolingual in their country of origin. I just recently got a new child from Ethiopia. So that's a language I don't know. I was going to ask Julian if she knew. I forgot how you say that language name, but it's another language that we're going to learn about. And with the language comes the culture. And it's really fascinating because what I find is that for us, we have learned different cultures and language as we work, and the families teach us what we have to know about them and what they need. And so I don't see, I see that a lot of the referrals come to us on that level because we're a little more or even more flexible than most agencies that have a tight curriculum to follow, certain like home visiting or when I see the way behavioral health works with the families, they're not tight on their curriculum or, their practice. They learn from the culture and they incorporate that into their theories of practice.
But I agree 100% with Paula that when you're working with a diverse population made up of multiple cultures and languages spoken, it's really important to take a generalist perspective because not every service model is going to match the worldview of the client that you're working with. And so, that's a great question. I think the idea of cultural competence is really an outdated, and that idea is kind of outdated in that who can really truly be competent in somebody else's culture? The approach now is really more of one of cultural sensitivity and curiosity and understanding the role of culture in terms of how it provides a protective function in people's lives, and also is the kind of the root of their experience and their worldview. And so what Paula said about learning from our clients and being inquisitive and asking them for what they want is really, and being sensitive to that, the role of culture is really the approach we take, more than saying, well, I'm going to be able to take some in-services or read a book and then become competent in Congolese culture. I don't think that's ever. It's really more about developing liaisons and connections. The other thing I think is important is to actually hire people and invite people from the community to take part in the conversation and to take part in the service. And that's one of the reasons I thought it was really so important to have Claudia and Julian join our conversation today, because we would not be able to serve the immigrant and refugee community if we didn't have their assistance in helping us to make those connections and build the bridges.
Yeah.
I think the other thing that I find important to look at when I'm with families is the resiliency factors, because people will highlight that to us. I can see how, for me it's significant what I see with the refugee immigrants as well as Mexicans or other people from other countries, because I grew up with a military dictatorship, and I remember coming to this country when I was 18, and people were doing things on the street, like demonstrating, and I was freaked out. I went to the bathroom to hide myself because I was afraid the military was coming to get us. It was like immediate, and I can see how that inner feeling can happen when you're in a situation in a different country and you've been used to being, having to protect yourself from a larger ghost that you don't understand, which in that case, for the refugee immigrants, I see it with being in a refugee camp. Not every person who is from Africa here came from a refugee camp. And those different refugee camps are different in the country in which they were at. So we cannot generalize what they're going through the same way as they cannot generalize what happened in my city in Brazil versus something that happened in another city in the same country, because things were very apparent in different places. So I think that for us to look at, culturally, my last training with the hospital was cultural humility. So I'm very culturally humble, because I I don't even understand my own culture, and that's very difficult, very difficult. So for that, I have great respect for people here, especially people that I'm working from Afghanistan, who they and other people from Middle East, as well as, of course, the others we've talked about, because you come to a country where you're nobody on somebody's land, and you were somebody in your own land, even if it was in the refugee camp. So you have to create a whole new identity that you have no idea how to even start. And then you have all people giving you some profile that you have not even thought you had. So it's so much more complex than what we learn on the books. So that's why I give a lot of respect for what they tell me is.
Claudia, do you want to talk about what it was like getting home visits and then like becoming a home visitor? Was it important for you to have a home visitor that spoke Spanish?
Yes, very important. Yeah.
Why do you think that having that kind of that service available in Spanish was important?
Because we can communicate better. When my home visitor was at my house, I could be, open and feel comfortable, because the same language, we were speaking the same language, and I would feel that, she understands what I'm saying. The interpretation is really good, to use it, but when you find someone that speaks, the same language, you feel more connected with the person. I remember they also had another resource or assistance. I remember my home visitor came with, I think it was Julian and Paula, and two doctors. They went in my apartment, and they asked me, for permission to go and observe my baby. They wanted to see how he was breathing, how he was asleep, or how was he, interacting. He was a newborn, and they went for 5 minutes, and they comfort me. They said, he's doing so good. I was a first time mom, so I I don't know if I was doing things right. And
Right.
so when you hear, oh, you're doing great, that's the right position, your baby should be, you want to hear that. You want to hear that you're doing a good job.
Right.
Job, But I was going to add it, just a little things about how important it is to have a home visitor. But when I came in the United States, as I said, in 2017, and then I had 3 kids. The youngest one was 6 months old, and I didn't know where to go. I didn't know anything about the country, the culture, but then I got this chance to have a home visitor from home visiting program here in Albuquerque. But the home visitor didn't speak my language. She was English speaking, and I didn't know any English. My English was like very broken. Then it was so hard to understand each other. She didn't use interpretation. then I was just saying yes, yes for something I didn't understand. And I was asking questions, she didn't understand what I was asking. So, but now I know, like, so right now I can experience like how it is important or very good to have the home visitor or that you speak the same language, even if you didn't come from the same country, like we came from Africa but different country, you know, it's Africa, but every country has their own culture, which is no different to others, but to other country, but of course it's a different culture. But as long as you speak the same language, or maybe you have many things in common, so I think the client feels really happy or comfortable. Yeah, that's why.
I'll make a comment about kind of negative practices and the existence of discrimination and racism. And the answer is yes, it exists, and that it has an extremely detrimental impact on a lot of the families that we're working with. And that one of the reasons it's important for social workers to have a very broad perspective and to be able to operate at different levels is that oftentimes people need case management and counseling, case management and advocacy support to help them navigate the system or to deal with teachers or school systems as it is to have kind of support to recover from trauma. And so that's one of the reasons if you're going to be working with immigrant or refugee populations, it's important to have case management and advocacy really intertwined with more clinical services. I think the case management and advocacy that we provide is as significant, if not more significant, in terms of promoting the welfare of the clients we serve. Back, the most important thing, I think, in terms of doing intake and assessment is to providing services in the language of the language spoken by the family. It's best if you can do it with a live person, a staff person that speaks that language. If not, then a live interpreter or a remote interpreter through the telephone. One of the analogies that I did early on in my career when I was doing a lot of therapy in Spanish is as a non-native Spanish speaker, I'm fluent enough in Spanish, but I'm definitely not a non-native Spanish speaker, is that I said doing family counseling in a language not your own is a little bit like crocheting with oven mitts on, right? It's difficult, but you can do it and it's awkward, right? And it gets easier and easier over time. Paula, talk about the groups that you're doing. We're doing a research project with Harvard. We're looking at the role of kind of connectedness, right? The idea of social connection. And so can you tell a little bit about the group that you're doing?
Julie is going to help me with this too. We have a group with 20 women on Zoom. This was supposed to happen in person, but we developed it in Zoom now. We have about 7 different languages. The comprehension of English goes from none to 10. And the none, the one that's 0, she's fascinating. She really engages with us in the group, right, Julian? She's watching her kids, but she has her phone and she's following them as she listens to everybody. But anyway, we are going to have 8 sessions, and the group is supposed to, we had some interviews with the families from home visiting program to find out who was somebody that they could count on in their immediate formal and informal network of support. They felt like they could use more of the home visiting person than sometimes their other people in their lives. So we as a group, and our principal investigator talked about, well, let's see if a group with all these parents that are interested in being there will break isolation and they can meet each other and start building that community. And they are. Now we are on we're going to have our 5th session. And we couldn't talk about everything and all the details about it. But the interesting thing is one mom moved to Colorado and she asked if she can stay in the group, if she can continue until the 8th session, because she really misses, she doesn't want to. This mother, her comprehension of English is maybe a 5, but she speaks in the group. But that's how much she feels connected with other people in the group. And then the other one that's an English speaker is moving to another part of Albuquerque, of New Mexico, and just asked me, please, can I stay in the group until it ends? Because I'm going to miss everybody. So that's how much I could see that at all levels, people are connecting.
I can add a little things to about the group. So this group is really helping moms. For example, I have one of the moms who came from Cameroon. She been here for 5 years here in the United States, but she doesn't know any African family here. She doesn't know. She has 2 babies, but she's still home. She's not working. She's just being home with the babies, so she doesn't go anywhere. So, but the groups, we are doing groups on Saturdays. So after the group, she always calling me. She said, "Oh, thank you guys for letting me join the group, because right now I have friends. I know the moms who we speak the same languages. She's Muslims. That's how they say Muslims, but she didn't. Yes, she didn't know where is the mosque, the Church of Muslim. But now she told me, oh, now I can go to church. I have the moms that they always calling me about just sharing the stories. She has connection. She's making connection with friends. She's very happy. She's so excited for the group.
And even the mothers who, like Julian said, the ones who are Muslim and they do go to the mosque, they find that this kind of group gives them some freedom to talk the way they like to talk for some reason, because they don't need to be behaving the way they are supposed to behave in certain situations, right?
And one other, I think, important element that we offer is we provide orientation and education about American norms and systems. For example, shortly after starting to work with the African refugee community, we found out that they were regularly being swindled and ripped off by unscrupulous con men. Who were stealing their children's social security number and their IDs, and offering to do their income taxes for them never getting their returns. And so we have done a couple of community forums to provide education regarding the tax system and how it works, and about ways that community members can protect themselves. We did a similar type of community forum shortly after the Trump administration took power, and there was all of the very intense negative anti-immigrant jargon and practices that were being put in place, and there were threats of massive immigration raids and roundups. We invited in experts from the Mexican consulate, as well as from some immigrant advocacy groups that were able to do trainings on the rights of immigrants, legal trainings about their legal rights, and about how they could manage those kinds of situations and defend themselves if they were confronted by authorities or people who were trying to threaten them. I can't really understate the powerful impact of all of the negative jargon, political jargon and discourse that's been happening in the country on how it's really had a very, very, very detrimental impact on people's emotional well-being. We see people who are contending with super, super high rates of anxiety. I personally have worked with children, Hispanic children of non-immigrant families whose parents are here legally and have no threat of deportation, being afraid that their parents were going to be deported. And so by providing education, that gives people a sense of voice and also gives them kind of a framework for which to defend themselves. Certainly state and local government are much more focused on equity and equitable access and equitable outcomes of services. You know, I see a lot of I see people coming into the clinic who feel very empowered to complain, you know, and to make noise and to defend themselves where that might not have occurred prior. I don't know.
That's the beauty of our job, you know. It's really awesome to see, you know, at first here we are helping them applying for whatever, right? And then all of a sudden, you know, I go or ask, you know, so do you need assistance with anything? Oh, no, I already did it myself. I'm like, oh, wow, you know, and I ask, how do you do it? Oh, on my phone. I have internet on my phone, and I renew my Medicaid, I renew my food stamps by myself. I'm like, oh, wow, you know, that's what makes me continue in this field, you know, empowering not just women, but also the husbands. And I like to see, you know, that the husbands can now see that their wives are learning also how to navigate the system.
One thing I have to say, when I was in Washington, D.C., it was 1986 and 87, and we had brown lunch almost every time because that's all they do. They work 24/7. It's crazy. That's why I would never live there. And they had brown bags where they talked about Albuquerque, New Mexico, and then grassroots projects here. And it was very well known and well, you know, it was something happening. So back then, I realized there was something going on here, and I saw a lot of that when I got here in 1990. Now I can see now with the new group of community and cultures, we have a lot of grassroots projects that people have no idea exist because they are very small groups that develop out of needs, and they embrace a certain group, and that group starts supporting the other groups and the other groups. And what Claudia just talked about is an example of it. This person had some agency, or not so much agency, but a grassroots program of some sort that, you know, empowered her to get to that level. So I think I have to say, now that I'm here since 1990, this is a very progressive place, even though we're the poorest almost country. I mean, not country. I feel like it's the country, state in the United States.
I think social workers do have a very important role to help with newly arrived people's acculturation in terms of educating them about the system and empowering them to be able to navigate and advocate for themselves. But that has to be done in a way that doesn't strip away cultural heritage or their identity. Mm-hmm. the whole idea of whitewashing someone's culture and making us into one great melting pot is really, I don't think that it was historically ever factual, but it certainly isn't the direction where I think as a profession we want to go.